Hyperprolactinemia. Prolactin, it is a polypeptide. It contains 198 amino acids and its molecular weight is around 22 kilodaltons. Circulates in different molecular sizes. Small 22,000, big 50,000 and large more than 1 lakh. Half-life is 20 minutes and is biologically active. Secreted in this form, discovered by Sticker, and one of the stress hormones, sleep-related circadian rhythm is seen and highest in early morning and lower in afternoon. Secreted in pulsatile fashion, and primary function is to enhance breast development during pregnancy and induce lactation. Source is lactotroph cells in pituitary and residual cells. No storage and no feedback is seen to the prolactin. And action on the breast gonads and insects. And features include shorter half-life, small, big and large, and cleared by liver and kidney. Estrogen increases the lactotroph cells of pituitary and thereby causing increased prolactin and hyperprolactinemia. Normal fasting levels should be less than 30 nanogram per ml, and in hyperprolactinemia it is elevated serum prolactin is seen. Pathophysiology is high levels of estrogen and progesterone in pregnancy. It will inhibit the lactation, and postpartum sudden fall of estrogen and progesterone, it induces the lactation, and prolactin will suppresses the gonadotropins and ovulation suppresses. What is the pathophysiology? Dopamine, prolactin inhibiting factor, that is PIF, has a dominant influence over prolactin secretion. Tonic inhibitory control by dopamine. PIF on D2 receptors located on the lactotrophs. Prolactin is secreted. Prolactin is increased by thyrotropin releasing hormone and vasoactive intestinal peptide. Suckling releases VIP, and it increases the prolactin, and decreased by PIF, GABA and dopamine. Presentation of hyperprolactinemia. 15-20% of cases has secondary amenorrhea and oligomenorrhea, and 30% has galactorrhea and infertility. What are the manifestations of hyperprolactinemia? Includes game on VH. Game on VH is the code for manifestations of hyperprolactinemia. Includes game on G for galactorrhea, non-prepared lactation, unilateral or bilateral, free-floating or expressive, and free-flowing or expressive, and continuous or intermittent. And A includes an ovulation, oligovulation, luteal phase defect, and menstrual disturbances, oligomenorrhea, hypomenorrhea, amenorrhea, and osteoporosis, and nervous manifestations like headache. And visual field defects include bitemporal hemianopia and hirsutism. In men, there is impotence, oligospermia, gynecomastia, headache, osteoporosis, and visual field defects. Game on VH. Causes of hyperprolactinemia. Physiological factors include pain, nipple stimulation, pregnancy, and pelvic examination, exercise, and sleep. And drugs include dopamine antagonists, chlorpromazine, promazine, and haloperidol, metoclopramide, domperidone, and sulpride. And dopamine depleting agents like reserpine, alpha-methyl-dopa, cimetidine, and verapamil, and narcotics like morphine, codeine, and methadone. And pathologic factors include hypothalamic causes like craniopharyngioma, Rathke's pouch tumor, cystic, solid, calcified, and seen in X-ray examination, and idiopathic. And hypothalamic causes like lactotroph hyperplasia and empty cellular syndrome, and prolactinomas, and microadenoma and macroadenoma, and lactotroph stimulators like estrogen, TRH, and amphetamine, and H2 receptor blocker like cimetidine and ranitidine. Empty cellular syndrome includes intracellular extension and subarachnoid space. Intracellular extension of subarachnoid space results in compression of pituitary gland and enlarged sella turcica. So, causes of hyperprolactinemia includes physiological factors, drugs, and pathological factors, and idiopathic. Pathological factors include hypothalamic causes like craniopharyngioma, lactotroph hyperplasia, and empty-cellular syndrome, and prolactinoma, and microadenoma, and macroadenoma, and dopamine antagonists, and dopamine depleting agents, narcotics, and lactotroph stimulators, amphetamine, H2 receptor blocker, and empty cellular syndrome is the main thing. Empty cellular syndrome. Intracellular extension of the subarachnoid space results in compression of the pituitary gland and an enlarged sella turcica associated with galactorrhea and hyperprolactinemia. Indications of prolactin assay: secondary amenorrhea, galactorrhea, ovulatory dysfunction, unexplained infertility, oligospermic men. Indications for SELA evaluation includes prolactin level more than 100 nanogram per ml, and nervous manifestations like headache or visual defects, and amenorrhea, galactorrhea, resistant to treatment, associated with negative progesterone, and galactoria, non-peripheral secretion of milk and confirmed by fat droplets in secretion using low-power microscopy. So, empty cell syndrome, indications of a prolactin assay, and indications for cell evaluation. So, what is the management of hyperprolactinemia? Four main causes: pregnancy, physiological stress, drug use, and hypothyroidism and pituitary tumors. Indication for treatment include disabling galactoria, amenorrhea, infertility, and presence of visual field defects and cranial nerve palsy and osteopenia and osteoporosis. Medical management includes dopamine agonists like bromocriptine, lizuride, quinagolide, and cabergoline. The respective doses are given here. So physiological is pregnancy, stress, drug use, and hypothyroidism and pituitary tumors. Similar to galactoria, we can write this hyperprolactinemia also. So indications for treatment include disabling galactoria, amenorrhea, infertility, and presence of visual field defects and cranial nerve palsy and osteopenia and osteoporosis. So semisynthetic ergot derivatives of ergoline, dopamine D2 receptor agonists, D1, both agonist as well as antagonist. This bromocriptine has this kind of nature and half-life is 3.3 hours. Side effects include nausea, vomiting, postural hypertension, headache, nausea and stuffiness, fatigue, and cramps. And these can be decreased by vaginal administration. And dose includes 2.5 to 10 mg per day. And cabergoline, its nature is ergoline derivative, high affinity and selectivity to D2 receptors. Half-life is 65 hours. So it's enough for once or twice weekly and more effective, better tolerated, and less side effects. And it is also a category B drug. Management. Surgical management includes transpenoidal surgery and the stereotactic radiosurgery and radiotherapy. Thank you.